Maybe I was a fool to hang on to someone that would never change. Maybe I was a fool, never let on just how much my heart was strained. Maybe I.
Alright, cardiovascular drugs we're going to look at today. So we'll look at this in slight detail, but of course we give cardiovascular drugs because the heart is not working properly or because the blood is not flowing correctly because of that. So of course, important to understand the normal flow and the normal components of the heart. So very brief descriptor. We have the superior and the inferior, or the cranial and the caudal vena cava. They bring deoxygenated blood from the body and they dump it into the right atrium. The blood from the right atrium then gets passed through the tricuspid valve, right here, also known as the right atrioventricular valve, into the right ventricle. And then that deoxygenated blood goes through the pulmonary valve, out through the left and right pulmonary arteries. It goes into the lungs at that point to become nice and oxygenated, and then from the lungs, the happy oxygenated blood comes through the left and right pulmonary veins, gets emptied into the left atrium, it gets pushed through the mitral or bicuspid valve, also known as the left atrioventricular valve, into the left ventricle, at which point the really thick myocardium of the left ventricle gives it a good contraction and pushes that oxygenated blood through the aortic valve into the aorta, and then of course into its component arteries. So that is the basic flow of the heart. A little bit of reminder, veins and arteries, the differences: veins carry blood toward the heart. Blood flow is passively directed by skeletal muscle contractions, also known as the skeletal muscle pump. There are there are valves present to prevent backflow, and there's no pulse present. Arteries carry blood away from the heart. Blood flow is actively directed by the muscle layer of the vessel wall. Valves are not present, and we can feel a pulse with arteries. And then, of course, we have the pericardium, which is the sac that sits around the heart. We're not going to talk too much about pericardium here because quite often the only time we're talking about it in this regard is pericardial effusion, whereby the fluid layer of the pericardium starts to acquire more fluid than normal. But I don't think we're going to talk much about pericardium and pericardial illnesses at all. Composition of the heart. This is an important one. We have, of course, the pericardium is the outermost three layers, so the fibrous pericardium, the parietal pericardium, pericardial cavity, which is filled with fluid, and then the visceral pericardium. And then we have the myocardium, which is the thickest layer of the heart, that's the muscle layer, and the endocardium, which is the smooth innermost membrane. Now the myocardium is the one that we'll talk about probably the most, because most defects we're discussing the myocardium. So flow in the heart, we talked about this in detail, so definitely have a review of this if you so choose. I will whip through this, but essentially the important part to note where the yellow circle is that in the right atrium is the sinoatrial node, and that is of course the pacemaker for the heart. It is essentially the fastest heart muscle cells to contract, and therefore when one heart muscle cell contracts, all of the heart muscle cells contract, so it's like a wave effect. So the location of the sinoatrial node is important, of course, which we'll talk about in a little bit more detail, but it's important to know that it's there and that it's the fastest little unit of cardiac bundle cells. The valves, which of course can cause problems, they have two sets of two types. There are semilunar valves, which are the aortic and pulmonary valves, and then they have the atrioventricular valves, left and right, which are the bicuspid and tricuspid, opposite though, right and left. These valves, of course, prevent backflow of blood, because when we get backflow of blood in the heart, then it's not efficiently getting pumped out of the heart, and also we can end up with blood clots in the heart, not ideal. So this is where it starts to become important. So normal cardiac function, essentially the heart receives impulses at the sinoatrial node. It sends the impulses down toward the atrioventricular node, which then sends the nerve impulses through the bundle of His, and then to the bundle branches into the Purkinje fibers. And the Purkinje fibers transmit that signal into the surrounding myocardium. So that is normal flow of electrical activity within the heart. And then we have this thing at the bottom right, and that is an electrocardiogram waveform. And what we're looking at is the PQRST waveform, or the PQRST complex. We use this a lot when it comes to electrocardiograms in order to identify the electrical abnormalities within the heart. We can't really identify the specific physical abnormalities with just an ECG, but sometimes they give us a clue as to where to look or where the issue might start from. They can detect an increase in cardiac muscle mass with things like cardiomyopathy and congestive heart failure. So looking at our PQRS wave here, PQRST, P is the atrial contraction, so that's the contraction of the atrium. Then we have a pause, which is the impulse working through from the sinoatrial node toward the atrial ventricular node, so it just takes a little pause. The QRS complex indicates ventricular contraction, and the T is repolarization period, when the cells are getting back to their normal. Then we have cardiac preload and afterload. Cardiac preload is pressure exerted on the muscle cells within the walls of the ventricles by the volume of blood just before ventricular contraction. More blood equals more pressure or preload, often equals leaky capillaries, ascites, or pulmonary edema. So ascites is, of course, fluid accumulating, typically in the abdomen, and pulmonary edema is fluid in the lungs. Cardiac afterload is the pressure the ventricles must create to eject that blood volume. Conditions in the body can cause an increase in afterload, and they have to be adjusted to get back to normal. Depolarization and repolarization, this is a review from from physiology, but the resting state is polarized, so the cells, the cardiac neurons, are negative inside the cell and positive outside the cell. Depolarization, during that phase, sodium, which is a positive ion, cation, rushes into the cell and it causes the cell inside to become positive. So it causes positive inside and positive outside the cell. So now that's depolarized, so it's positive on both aspects. This is essentially the firing of the cell, that depolarization. Then the body resets the cell to be polarized, so it becomes negative on the inside, positive on the outside. This is the refractory period, so when the body is actually in the process of repolarizing the cells. And during the refractory period, the nerve cells or the muscle cells, they can't refire. So they can't accept another impulse to fire as long as they're in the refractory period. So keep that in mind, because we'll talk about that when we come to some of the cardiac drugs. So resting state we have here, it's polarized. So we've got potassium, and then what you don't see is the chloride and the carboxylate ions, which are both negative. They are on the inside of the cell as well. So with that, chloride and carboxylate, along with a few potassium, it maintains a negative charge on the inside of the cell. And then the sodium maintains itself on the outside of the cell. And it's nice and positive on the outside of the cell. Now during depolarization, this is that picture here, the little sodium gates open, and thanks to the concentration gradient and also to the fact that opposites attract, the sodium is drawn in toward the cell, inside the cell, as soon as those gates are opened, and it creates a depolarization. So now it's positive on the outside because there's still some sodium on the outside, but it's also positive on the inside because the sodium has tipped the scales. Normally, once repolarization starts, the sodium-potassium pumps remove any straggler sodium or potassium ions from the inside or outside. So the sodium-potassium pumps essentially turn on with ATP using energy, and they just plop the sodium ions, they take them out of the cell, plop them outside, they take the potassiums from outside, put them inside. In cardiac cells, they're different. So the sodium and potassium pump are working away, but slow sodium channels are allowing constant leaking of sodium back into the cell. This will happen until the cell reaches its threshold for depolarization. This is the reason that cardiac cells can spontaneously fire. Okay, so that's something that we have to keep in mind when it comes to some of these medications. It is suggested that the sinoatrial node has the most rapid rise to threshold, thus setting the pace for the heart. And that's why we call the sinoatrial node the pacemaker, because all the cardiac cells will fire as soon as the first one fires. So they all keep up that wave with the pace of the first cell to fire. So that's the cells within the sinoatrial node, of course, have the lowest threshold and therefore fire first. So then we have the refractory period. And like I said, the nerve can't fire until the cell is more or less back to its resting state. The wave of depolarization cycles around the atria until it recognizes that all the cells are in the midst of depolarization. If the animal had a shortened refractory period, the heart muscle could continuously fire. This is called fibrillation. So the role of the autonomic nervous system in cardiovascular function. Autonomic, don't forget, it's automatic. So we have sympathetic nervous system and parasympathetic nervous system, and essentially the autonomic is a continuous tug of war between the two. We probably know this, the sympathetic nervous system, it increases the heart rate and the force of contraction, it elevates blood pressure, causes constriction of peripheral blood vessels, decreases perfusion to the sort of outlying organs and superficial vessels, and, and it decreases the activity of the gastrointestinal tract. Also dilates the bronchioles. So all of these functions of the sympathetic nervous system help that body to survive in a fight or flight syndrome. So a lot of times, and we'll talk about the different receptors, but a lot of times we're choosing to use drugs that play on the sympathetic nervous system in order to increase contractility, increase the amount of blood flowing into the heart, etc., etc. So we'll talk about those. So the autonomic nervous system receptors, the sympathetic nervous system response, epinephrine and norepinephrine, they bind to adrenergic receptors. Drugs that bind and have intrinsic response are called adrenergic agonists. Drugs that bind and have little intrinsic response are, of course, called adrenergic antagonists, kind of like hydromorphone and naloxone. So to produce the sympathetic nervous system response, neurons of the sympathetic nervous system release the neurotransmitters epinephrine and norepinephrine. These compounds bind to specific types of receptors called adrenergic receptors to produce the fight or flight changes. Drugs with intrinsic activity, like I mentioned, can mimic the effects of epinephrine and norepinephrine, and they're the ones that are called agonists. In contrast, drugs that are able to bind to these receptors and have no intrinsic activity means that they slow the heart rate down, essentially. Those ones are the antagonists. The adrenergic receptors. So I will give this to you as a cheat sheet because it's good just to have this in front of you in order, if you're in my class and you're listening to this, in order to have this just to review. So beta 1 receptors and beta 2 receptors. Essentially, beta 1 receptors, they increase the heart rate, the strength of contraction by the cardiac muscles, and the speed of depolarization wave through the heart's conduction system. Stimulation of beta 1 adrenergic receptors by norepinephrine or adrenergic agonist drugs, I have such a hard time saying adrenergic, is responsible for the racing heart, so tachycardia. That's typically experienced during exercise, fear, or excitement. An easy way to remember that beta 1 receptors are responsible for this is to think of B, beta, referring or standing for beat. Something to think about. Memory tools. Beta 2 receptors are found in smooth muscles surrounding the blood vessels of the heart, skeletal muscles, arterioles, and the terminal bronchioles in the lungs. When stimulated, beta 2 adrenergic receptors cause smooth muscle to relax, so to dilate. Therefore, beta 2 receptor stimulation causes dilation of blood vessels in the skeletal muscle in the heart, so it causes vasodilation overall, and dilation of airways in the lungs, so bronchodilation. Drug stimulation, if it's a beta agonist, it's likely to cause at least some effect on both beta 1, beta 2 receptors. A good example of this is a bronchodilator, salbutamol. That's a common one that people use for the incidence of asthma attacks and also for cats when they're having asthma attacks as well. When we use it as a form of bronchodilation, it also follows with very immediate tachycardia, very immediate and very short-lasting tachycardia. And then we have the adrenergic receptors, so the alpha receptors. So we have alpha 1 receptors, which is for the GI tract and skin. They decrease the blood flow to the GI tract and skin, so in order to get that blood pumping to the heart and the lungs. And alpha 2 receptors, and they're located on the ends of adrenergic neurons, and they are involved in the regulation of the release of norepinephrine and epinephrine. Okay, so then we have the parasympathetic nervous system. So this one's all about the rest and recover. So if we're talking about the sympathetic nervous system, just think of it fight or flight. And parasympathetic, it's all about the R. So the R, rest and recover, para-R. In this case, acetylcholine and cholinergic receptors are involved, and they slow the heart rate, they increase blood flow to the gastrointestinal tract, and they decrease the size of the bronchodilation. Both the sympathetic and parasympathetic are always working, and that's something that we have to keep in mind. So it's always this tug of war. So it just depends on which one is showing more dominantly at that point in time. When we use beta blockers, which are sympathetic nervous system antagonists, we often see symptoms of the parasympathetic parasympathetic system showing up. When we give parasympathetic antagonists, which is called an anticholinergic, we see signs of the sympathetic nervous system showing. So they're always both working. It just depends on which type of drug we're administering to block the effects of one in order to show the other. So things to keep in mind. Treatment of cardiac disease is always complicated. An unhealthy heart is an unhealthy body. An unhealthy heart alters the normal absorption, distribution, and metabolism and elimination of drugs. Our role, of course, is to know the intended effects of the drugs, determine whether or not the therapy is working, so be part of the monitoring process, detect toxic side effects, and listen to the clients. Challenges: cardiac drugs have complex mechanisms of action that can be difficult to understand. Several cardiac drugs may be used simultaneously, so drug interactions must be considered, and many cardiac drugs have serious side effects that have to be anticipated. In addition, impaired cardiovascular function can alter all of that absorption and metabolism, which is crazy when considering the other drugs that we have to give and how the cardiovascular system could actually affect those. The veterinary professional, so us as an RVT, we have to have knowledge of normal and abnormal cardiac physiology in order to understand the intended effect of cardiac drugs, as well as to determine the goals and whether or not that patient's treatment is reaching the goals intended. So then looking at some terminology, we've got congestive heart failure. So if you see CHF, it's congestive heart failure. Essentially, it's inefficient pumping of the heart and fluid ends up backing up. Congestive heart failure, they're normally sad cases in the end, and they end up with a ton of fluid on the lungs because the fluid accumulates, the heart's not able to pump out appropriately, so we get plasma and other fluid floating around the body. Dilated cardiomyopathy, there is enlargement and weakening of the left ventricle. So I think of dilated cardiomyopathy as a floppy heart, a heart that is maybe a bit lazy, doesn't really want to contract, doesn't really want to work very hard. And then we have hypertrophic cardiomyopathy, where a portion of the heart becomes thickened and often quite stiff, which impacts the heart's ability to pump. Arrhythmogenic right ventricular cardiomyopathy, this is known as boxer cardiomyopathy, and it happens when there's a fatty infiltrate in the right ventricular myocardium. And it almost always only happens to boxers and boxer crosses. It's an anomaly of that breed. And then the term edema we might mention, and that's the abnormal accumulation of fluid within tissues of the body. Hypertension is high blood pressure, pressure in the arteries is consistently high, and hypotension, low blood pressure, pressure in the arteries is consistently low. And this is just a little picture about cardiomyopathy. So we've got normal heart, okay, normal average thickness of the ventricle walls of both the right and left. Normally the left is, regardless, thicker than the right. And then we have hypertrophic cardiomyopathy, where we have excessive contraction, a little bit of impaired relaxation, and we have thickened, really thickened left ventricle in this case. So that's cardiomyopathy. So you can imagine with a thickened ventricle overall, thickened and stiffened ventricle, the heart isn't able to efficiently pump. Then on the other side of the spectrum, we have dilated cardiomyopathy, which you can see has a thinned out, stretched out wall of the myocardium, which getting that one to pump efficiently and effectively can be really challenging because it becomes this lazy kind of floppy heart. All right, here we go, talking about some cardiac drugs and the cardiac patterns. Okay, so arrhythmia, you need to know about arrhythmias. They are the abnormal pattern of electrical activity in the heart. Causes could be ectopic foci, which are areas of damaged cardiac cells or electrical faults. Could be damaged heart muscle cells overall. Could be abnormal frequency of the sinoatrial node firing. And you can look at this video. If you have the actual PowerPoint video, you can look at the little video. It's very helpful. So here's an example of a couple of abnormal heart rates. So again, it's abnormal pattern of electrical activity in the heart. That's an arrhythmia. And arrhythmias can be really difficult to pick up. That's one thing that everybody needs to know about. When you're learning how to take a heart rate, we always take it within 15 seconds and multiply it by 4 to get a beat per minute. And I think as we get more involved in the field, a little bit more used to what we're doing, we tend to go down to like 10 seconds or 5 seconds for heart rate. But you have to appreciate that you might not be able to actually hear an arrhythmia, especially an intermittent arrhythmia, in 5 seconds. So it's best especially if a dog has any sort of cardiac signs otherwise, or dog or cat too, just take that extra time, even up to a minute, just to sit there with your stethoscope and listen to their heart to ensure that you're not missing a cardiac arrhythmia that might come on intermittently. Okay, so we'll talk about some antiarrhythmic drugs. So antiarrhythmic drugs are classified as belonging to class 1, 2, 3, 4 based on their mechanisms of action. The sodium channel blockers are class 1. We've got lidocaine, quinidine, and procainamide. Mexiletine is an orally administered drug in the same class as lidocaine, and it works primarily by decreasing the rate of sodium movement into the cell through the sodium fast channels. This decreases that spontaneous depolarization and just general depolarization of ectopic foci. Mexiletine is often used for boxer cardiomyopathy. Okay, keep that in mind. Lidocaine is commonly used as an IV bolus or CRI to prevent and treat ventricular fibrillation. So VPCs or PVCs, whatever you want to say. So that's premature ventricular fibrillation or ventricular premature contraction. Same thing, or either way it's contraction. So this prevents the influx of sodium into the cell, and therefore it reduces the likelihood of depolarization because now we've got all that positive sodium ions inside the cell. So we've got positive on the outside, positive on the inside. It maintains we've got an influx of sodium on the inside. Therefore, so this also prevents the leaking of sodium and subsequent automaticity of contractions. Okay, so the leaking of sodium, so that slow channel access of sodium. So here, I call it VPC, so ventricular premature contractions. So right here you've got a normal P, which is the atrium contracting, then QRS complex is the ventricle contracting, and then you have T wave here. T wave is also positive too, as per normal. Either way, here we've got P, QRS, T, and then here you have, there's no P wave is missing, and then, so essentially when the atrium is supposed to contract on this wave, the ventricle just pushes it out of the way and decides to contract. So this is a typical VPC, where the ventricle is contracting before it's supposed to, and it kind of looks like just a giant loop-de-loop, just a giant up and then down, up and then down. So that's what you're looking for on ECGs to identify VPCs, at which point we often give lidocaine. Common scenarios. So this bad boy, as you might know, is GDV, gastric dilatation volvulus, whereby the stomach of a typically fairly large dog, so like German Shepherd size and up, gets bloated and then twists over on itself. And we go to surgery with these guys most often if they're in good, decent condition. And before surgery, we often administer a lidocaine bolus and then maintain them on a lidocaine CRI, in part because lidocaine acts as an antiarrhythmic. So when we correct this huge stomach flip, this stomach torsion, oftentimes the vena cava was entangled up with it and was somewhat compressed or twisted, and we get a rebound effect of blood flow back up to the heart, which can overwhelm the heart to some degree and cause VPCs. So we don't want that to happen. There's a lot of cardiac issues that can happen with gastric dilatation volvulus. So quite often we'll give lidocaine preemptively as a bolus and then often as part of a CRI to help prevent those ventricular fibrillations from occurring. All right, so lidocaine, just to note, it is ineffective for atrial flutter or fibrillation. So we're talking about ventricular fibrillation in these cases. We do have to be very cautious with lidocaine in cats. It will cause CNS effects of CNS toxicity in cats, which means seizures, muscle tremors, etc. Maximum 2 mg per kg. So with cats, what we often have to think about is if we're giving a lidocaine bolus of any sort, if we're also doing any local blocks that involve lidocaine, we have to be very cautious of the total amount that that cat can get. Likelihood of an increased atrioventricular block, which is the wave of depolarization, essentially isn't sent past the AV node. So if we look back at our flow of electricity through the heart, essentially, it goes to the sinoatrial node and then down to the atrioventricular node, and that causes the ventricles to contract. So there's potential that we get an atrioventricular block with this and a sinus arrest. Okay, so that's a side effect of lidocaine. Toxicity in general, so cats, but also with every animal, like I mentioned, it's CNS effects, so seizures, muscle tremors, and whatnot. Typically, these are short-lived because it's pretty quick to be metabolized in the liver. A lot of clinics carry epinephrine, so lidocaine with epinephrine, and this is typically the local anesthetic of choice at your dentist's office. So we may use lidocaine, lidocaine with epinephrine as a local anesthetic to cause local vasoconstriction, to keep the lidocaine in the local tissues for a longer period of time. It prevents reuptake of that drug into the blood circulation. That's what the epinephrine does. But in animals, we have to be so cautious. We have to be so cautious because we never, ever, ever want to give lidocaine with epinephrine intravenously or intratracheally. So in the case of an emergency, we have to be very, very careful that we're grabbing lidocaine neat, which is just lidocaine hydrochloride, and not lidocaine with epinephrine. It will cause typical symptoms associated with epinephrine tachycardia, and if we're already battling ventricular tachycardia or ventricular fibrillation, we don't want to be adding epinephrine. So that's a huge warning that everybody needs to be made aware of. So lidocaine is a class 1 antiarrhythmic. Generic name, typically it's lidocaine, or lidocaine neat is a trade name as well, and that means lidocaine without epinephrine. The mode of action, it inhibits the flow of sodium into the cardiac cells, thus inhibiting depolarization. Positive effects, it's the number one choice for arrhythmia and VPCs, and we're talking about arrhythmias and then ventricular fibrillation. It allows the sinoatrial node to regain control of depolarization. Side effects, too much, it causes CNS stimulation, and in cats, toxic in relatively low doses. Another thing I should mention, positive effects, it does any toxic effects that are CNS toxic effects, such as the seizuring or muscle tremors, they're typically short-lived, so that's something to be keeping in mind. Now down here I said that it was IV only, but I should have added in, we can also give it via the endotracheal tube. So we can actually give it essentially directly into the trachea as well in the case of an emergency. All right, so then we have sodium influx blockers, continued, carrying on with these guys. So procainamide and quinidine belong to the same general class as lidocaine. They differ from lidocaine in their ability to control both ventricular ectopic foci as well as atrial flutter or fibrillation. These drugs also increase the refractory period of the electric activity within the heart, and we know that another impulse can't start a contraction if it's during the refractory period, if that refractory period is happening. So that's really beneficial to these drugs in particular. For now, we use it as an oral route for long-term treatment, and it's important to mention that quite often a lot of times in atrial fibrillation in horses, and I think I added a story to the playlist about this. In horses, they'll often start off with mexiletine, as an intravenous medication. So that's the one that they also use in boxer cardiomyopathy. They'll use that as an initial intravenous injection and then move on to quinidine as an oral dosage for these horses. So that's a clinical application. So sodium influx blockers, procainamide and quinidine downfalls, of course, judging by the look of this dog, vomiting, diarrhea, and anorexia. They have an antivagal effect that can cause tachycardia because the vagal nerve stimulation causes bradycardia. So if they have antivagal nerve effect, it can cause tachycardia, which is really unfortunate if we're trying to get a hold of arrhythmias. And caution when using with digoxin, which I'll talk about in just a minute. So going back to the vagal nerve, it acts on the parasympathetic system, so that's that rest and recover, causes bradycardia or lower heart rate. And then of course, when it's stimulated, does the opposite, when these sodium influx blockers affect it, they cause tachycardia. The drug, so essentially, with that, the drug has an antivagal response which can suppress the parasympathetic system and allow the sympathetic nervous system to show through. So what I wanted to point out here is just a reminder that with the autonomic nervous system, we have parasympathetic and sympathetic nervous system. Both of them are constantly at play. So both of them, it's a tug of war. And what we do is use agonists or antagonists to suppress one to show the signs of the other. So in this case, when it has an antivagal effect, we're suppressing the effects of the parasympathetic, so the rest and recover state of the animal, and which allows the sympathetic nervous system to show through, thus causing potential tachycardia. Going back to digoxin, it's a drug to increase the contractility of the heart. We'll talk about it. When used together, quinidine knocks digoxin off its receptors and decreases the elimination. Therefore, more maintains itself in the plasma. We often reduce the dose of digoxin in half when using quinidine because we don't want digoxin toxicity. Digoxin toxicity is not ideal, and we'll talk about that shortly in this chat. So here's our chart. Procainamide, class 1 antiarrhythmic, can be given as an IV form, oral tablets, or slow release tablets. Generic, trade names, Propanolol is the human version, otherwise we just call it procainamide, which is generic. Mode of action, it inhibits the flow of sodium into the cardiac cells, thus inhibiting that depolarization. Benefits, it works on both atrial and ventricular fibrillation. And again, it allows that SA node to regain control of depolarization. It's pretty well tolerated. Challenges with dosing of slow-release tablets, always keep that in mind, and it's not readily available for veterinary use. Quinidine, which I feel like I've been calling quinamide. Anyways, it's quinidine. It's a class 1 antiarrhythmic that we give it as an oral tablet. Cardioquin is a trade name, or quinidine as the generic. It inhibits the flow of sodium into the cardiac cells, thus inhibiting depolarization, just like its buddy up top. Works on both atrial and ventricular fibrillation and allows the SA node to regain control. Side effects with this one, more GI upset, and of course that interaction with digoxin, which isn't unrealistic that an animal would be on both quinidine and digoxin. All right, then we get into beta blocker antiarrhythmic drugs. These are class 2 antiarrhythmics, and they're recognized by the OL ending on the drug names. Propanolol, Atenolol, Esmolol, Metoprolol, and Carvedilol. They work by blocking the beta-1 sympathetic nervous system receptors on the heart. So if we're blocking those sympathetic nervous system receptors on the heart, it means that we're going to allow the parasympathetic effects to show through. So that is the rest and recuperate, or rest and recover. So blocking I just mentioned that, so it helps reduce the generation of ectopic foci and arrhythmias through this method. And these are often used on weak hearts that have arrhythmias and then that's great. And then just one thing to mention too, sotalol tends to be used in boxer cardiomyopathy as well, which I didn't mention up there. So beta blocker antiarrhythmic drugs, remember that we are blocking the sympathetic nervous system response, so now we're allowing the parasympathetic nervous system to show through. Negative attributes, overdose slows conduction through the heart. Heart block can occur. They're contraindicated if heart failure is suspected. And long-term use increases the number of beta receptors which creates upregulation. So the heart, when we have continued use, the heart actually develops more beta-1 receptors, and therefore they become less affected by the same dose of medication. They also become very sensitive to epinephrine and neurotransmitters that stimulate the sympathetic nervous system. So if that makes sense, the longer we use it, the greater the number of beta receptors start to develop, which means, of course, it's going to have less and less of an effect over time. Also, if for some reason we administer epinephrine to this animal and they have an increased number of beta receptors, they're going to have a heck of a response to epinephrine because they have more of those beta receptors. So we wean off over several days to several weeks. Because of all their new beta-1 receptors, even a normal dose of the body's epinephrine can cause a high level of tachycardia. So we often monitor the weaning off time by checking their pulse rate. So again, because of all those beta-1 receptors that have developed in the heart now, we want to wean off slowly so that the body's natural epinephrine doesn't sort of put the heart into overdrive. And then we have propanolol. It's really common. So it's a non-selective beta-1 and beta-2 blocker. It's used in cats with hyperthyroidism or hypertension. It's used in dogs with atrial and ventricular arrhythmias, as well as hypertrophic cardiomyopathy. Side effects and hypertrophic cardiomyopathy, that's fine, it's mostly in dogs. Side effects could be bradycardia and hypotension and bronchial constriction. Because it's non-selective, it can cause that unwanted bronchial constriction because it's not only blocking beta-1 but also blocking beta-2. And beta-2, don't forget that it's responsible for bronchial dilation. So therefore, the constriction of the parasympathetic nervous system sets in. Okay, so again, we're blocking one system, you start to get effects of the other system showing up. So our chart, propanolol. If you can hear my cat snoring, I apologize. It is a Beta blocker antiarrhythmic, class 2 antiarrhythmic. I've never heard of a common trade name that we use. We often just order it in as Propanolol. It blocks the effects of beta 1 and beta 2, allowing the parasympathetic effects to show. It reduces the chances of ectopic foci, reduces the heart rate, slows the conduction rate. It's hard to balance with congestive heart failure. Heart block can occur, so we have to wean off very slowly to avoid that rebound tachycardia. Can cause bronchospasm as well as that bronchoconstriction, and bradycardia and hypotension potentially as well. So just to note, decreasing the sympathetic system effect on the body includes increasing contractility. So in cases of a weakened heart, such as congestive heart failure, unable to pump blood adequately, that's what congestive heart failure is, we actually would like the increased contractility. These block that and therefore can be detrimental to congestive heart failure. Okay, so we typically don't use these in congestive heart failure. Just to note that drugs that decrease the contractility of the heart are called negative inotropic drugs, and we'll talk about some positive inotropic drugs soon. All right, Atenolol is a beta 1 blocker. Its uses or side effects, same as propanolol. First dose might cause profound bradycardia. Sotalol and imiodarone, they inhibit potassium channels, making them slower to open and thus prolonging the repolarization period. Okay, so those potassium channels, which would allow potassium to escape, they're changing that up. So they're preventing it from reaching that repolarization period, which means that they're in that refractory phase. And we know that another impulse can't come down the pipes if the animal's heart is still in the refractory phase. They are non-selective beta blockers. They slow the potassium channel openings. They're used for ventricular arrhythmias in dogs and cardiomyopathy in boxers, contraindicated with hyperthyroidism and increased insulin efficiency. So then we have calcium channel blockers, diltiazem, amlodipine, and verapamil. They block the calcium release into the cardiac muscles, and they prevent the depolarization and automaticity of contraction. They are negative inotropic drugs, and we don't want to use those for congestive heart failure. They're often used in hypertrophic cardiomyopathy, and they can actually reduce the size of the left ventricle in myocardium, the size of the left ventricle myocardium, which is beneficial in cardiac or cardiomyopathy, hypertrophic cardiomyopathy. Sorry, I messed up my words there. So positive inotropic drugs, we're going to look at positive inotropes. They increase the strength of contraction of a weakened heart. Catecholamines increase the strength of a contraction of a weakened heart. So this is norepinephrine, epinephrine, and dopamine. Epinephrine is used for cardiac arrest. It stimulates heart contractions. It undergoes peripheral vasoconstriction, and we often use it in anaphylaxis. Side effects, of course, cardiac arrhythmias, so we have to be very cautious of the patients that we use this for, and down regulation. Drugs that are catecholamines or mimic the effects of catecholamines are called adrenergic drugs because the adrenal gland produces catecholamines. Catecholamines naturally increase the contractility of the heart due to their direct effect on the sympathetic nervous system. Peripheral constrictors, they increase the blood pressure or blood volume to the heart. And the more we use it, it decreases, so this is the opposite effect, it actually decreases the number of catecholamine receptors on the heart. So with positive inotropic drugs, pimobendan is one. It's an inodilator drug. It is known most often as vetmedin. And it acts as both vasodilator and a positive inotropic drug, which is great. It's used for canine congestive heart failure and cardiomyopathy. It decreases blood pressure and causes decreased cardiac preload and afterload. This in turn lessens the burden on a weak heart. So far, so good. There aren't that many side effects, if at all. It's often used in conjunction with an ACE inhibitor. Positive inotropic drugs, we have digoxin. So essentially, digoxin shuts down the sodium-potassium pump and therefore allows little bits of sodium to get into the cell. When it does this, the calcium, which we haven't really talked about much, but the calcium is displaced from its holding area within the cell, and then the calcium becomes more available to the cell to strengthen the actual contractions because it's a positive inotropic drug. This does create a risk of spontaneous arrhythmias because we have sodium leaking leaking into the cell, which can push it toward that depolarization threshold. So that's its mechanism of action. Digoxin, like I said, works with this method of action. It's the most commonly used long-term positive inotropic drug, and it improves cardiac contractility and availability of calcium. It's on an atrial node effect. It slows the heart rate down and it delays conduction through the atrioventricular node, and it treats atrial fibrillation. It is a cardiac glycoside, which is a toxin found in nature. One of the side effects of digoxin therapy can be the appearance of arrhythmias. It's derived from the foxglove plant. Like I mentioned, it's a cardiac glycoside, so toxins found in nature. That's it there. That's the beautiful foxglove plant. One of the side effects of digoxin therapy can be the appearance of arrhythmias, which is really unfortunate because it's allowing that slow leak of sodium into the cardiac cells, which means that it can cause the cardiac cells to reach that threshold sooner than preferred. It's derived from the foxglove plant, and that was that plant shown in the last slide, and it's a cardiac glycoside. Has a very narrow therapeutic index. Essentially, toxicity will cause vomiting, anorexia, and diarrhea, so bradycardia. Skipping of the QRS complex can occur. We have to look for that on the ECG, maybe a faint P wave. Can cause hypokalemia, likely toxicosis, or if they already have hypokalemia, we have to be very cautious in using this. And caution with use of diuretics. So IV fluids, oftentimes rehydration is what is necessary, and then elimination by the kidneys. The half-life in dogs is 15 to 50 hours, and in cats it's 24 to 36 hours. And we always have to monitor the plasma concentrations, especially with renal impairment. Very important. So here's the information on digoxin. It's a positive inotropic drug. It's often compounded. It improves cardiac contractility and calcium availability in the muscle. Can be used in cats and dogs. Has a long half-life, which equates to more client compliance. Has a narrow therapeutic index. Likelihood of toxicity. It's eliminated via the kidneys. Plasma levels should be monitored closely, and close monitoring for toxicity is very important. Caution with double dosing. So double dosing in this case can cause extreme toxicity that will last to the period of the half-life at least. So in that case of toxicity, we would bring these animals in. Depending on when they gave the pill, we might give activated charcoal to sort of absorb the toxins in their stomach, and then hook them up to IV fluids to help increase the excretion through their kidneys. We often give this as oral tablets or as an oral elixir. Okay, moving on to vasodilator drugs. Vasoconstriction is one of the normal protective mechanisms by which the autonomic nervous system regulates arterial blood pressure. Vasodilator drugs increase the diameter of blood vessels. Vasodilators are often classified as pure arterial vasodilators, pure venodilators, so they just dilate veins, mixed vasodilators that balance dilation of both the arterial and the venous system. Arterial vasodilation directly reduces the resistance that the heart must overcome to successfully eject the blood from the ventricles. All vasodilator drugs have activity on both the arterial and the venous side of the circulatory system. We have to be very cautious when using vasodilators. Initial use often causes hypotension, so the vet tends to start very slow with a very low dose and increase until we see the symptoms that we want to see, so reduction in hypertension. Low dosing with other cardiac drugs on board because they all interact with each other, and it requires long-term monitoring to adapt to these drugs. So we'll start talking about arterial vasodilators. Amlodipine and hydralazine are the two common ones. They are calcium channel blockers. They reduce the afterload by dilating arteries. They ease the work for congestive heart failure patients, and they're used in dogs and cats for hypertension. Cats, typically we see this as secondary hypertension, so typically it could be kidneys that are the primary reason. An arterial vasodilator, it's used in dogs and cats for hypertension overall. It also reduces the effects of hypertrophic cardiomyopathy, which is really great in cats. So looking at their chart, we've got amlodipine and hydralazine. They're both calcium channel blockers. They reduce the afterload by dilating the arteries, and they ease the work for congestive heart failure patients. They are arterial vasodilators used in dogs and cats for hypertension, and they actually reduce the effects of hypertrophic cardiomyopathy. They can cause fluid retention, we have to be aware of that, and typically they're prescribed with a diuretic or with a beta blocker. Most often we're administering these as an oral format. So then we have venous vasodilators. Nitroglycerin is our primary example, which I have not used. I'm certain that there are reasons for using it with congestive heart failure. I just haven't actually seen it used much in clinic, so it's truly an emergency type drug. Primarily, it relaxes the blood vessels on the venous side of circulation, creates lower blood pressure and better supply of the blood to the heart. The blood volume shifts from the pulmonary circulation, so pulmonary artery to lungs to the pulmonary vein, to the systemic circulation, and reduces that pulmonary edema formation. Because again, if that area of the heart isn't working overly well, it doesn't have very strong contractions to pump that blood to the heart, we start getting fluid backed up around the lungs. So this reroutes that circulation away from pulmonary circulation to the systemic circulation and reduces pulmonary edema. It dilates the heart's coronary arterioles and improves blood flow to the actual myocardium. And the drug is metabolized very quickly and has a half-life measured in minutes, which is crazy. It's always important to remember that in congestive heart failure, everything is overloaded because of a weak heart. So because of this, the vessels get really backed up when they are on their way back to the heart. Giving that nitroglycerin can help open up those veins and allow passage of blood to the heart, but it's still a weak heart, okay? So we're really just supporting a really weak heart. It's the emergency treatment of congestive heart failure. We also use it as treatment of pulmonary edema and ascites, so accumulation of fluid in the abdomen. Has significant first pass effect, and that negates the use of this drug via the oral route. Typically, it's administered as topically, applied as a cream, or as a transdermal patch. With that, we have to be very, very cautious to ensure that either ourselves, normally it's us, not so much the client, when we are using this drug, we are wearing gloves because we do not want the effects of nitroglycerin on our healthy hearts. So looking at nitroglycerin, I don't know of any trade names. We see it ordered as nitroglycerin, comes in as nitroglycerin. It dilates the venules and coronary arterioles, so it allows better passage of blood to the heart, but don't forget that it's still a weak heart. Okay, it's still a heart that's not functioning very well. Positive effects: it lowers the blood pressure and better blood supply to the heart. Easy application for clients if it is them giving the nitroglycerin, and it improves cardiac output. Side effects: it's applied as a cream or a patch, so of course with that we have to have caution when using, and we can't allow the dog to lick. Alright, then we have mixed vasodilators. So these are the combined benefits of arterial vasodilation, which is the lowered arterial blood pressure and ease of ventricular ejection of blood, and vasodilation, which is lowered pulmonary circulation blood pressure, decreased edema formation. We'll talk about the one that we talk about the most is nitroprusside, which is a potent mixed vasodilator used to stabilize dogs or cats with severe dyspnea caused by pulmonary edema secondary to heart failure. ACE inhibitors are also mixed vasodilators. So they are angiotensin converting enzyme inhibitors. Crazy. That's why we call it ACE inhibitors. Enalapril, also known as Enacard, Captopril and benazepril are the most commonly used. They relax the smooth muscles of both arterioles and veins. They're suggested to have inotropic properties, positive inotropic properties, but not sure why. Cardiologists really love ACE inhibitors in congestive heart failure patients. Caution with patients who are on potassium-sparing diuretics or are hyponatremic, because we can get further imbalance of increased potassium and low sodium. For this one, we don't need to keep them on a low sodium diet, so we don't have to worry about that because it's not going to cause an accumulation of sodium. So animals who have congestive heart failure or left-sided heart disease show marked improvement with these drugs. Healthy animals show very little effects, which is kind of good to know in case we're giving them accidentally in the wrong patient. Vasodilators that exert their effects on arterial and venous vessels by blocking the angiotensin-converting enzyme, so ACE, and thus preventing formation of angiotensin II, the potent vasoconstrictor, and aldosterone, the hormone that increases blood volume by causing sodium retention. So essentially, they are inhibiting those two mechanisms of action, which thus prevents retention and prevents increased hypertension. Many veterinary cardiologists believe that stimulation of the renin-angiotensin system has profound effects on cardiac disease beyond the vasoconstrictive or increased blood volume effects, which is kind of interesting. Hypokalemia can result from ACE inhibitors blocking aldosterone production. Aldosterone normally causes sodium and water I'm not going to get into that. So mixed vasodilators, nitroprusside, trade names. I don't really have any off the top of my head, and I haven't seen any in clinic come back that way. Could be likely human medication mostly that's adapted for use in veterinary medicine. It relaxes the muscles and blood vessels, allows them to dilate. Beneficial in cases of pulmonary edema secondary to heart failure. Side effects, I don't have any noted. There aren't major side effects that are huge precautions. Next up, we have enalapril, captopril, and benazepril, which are ACE inhibitors. Enalapril, most often you'll know it as Enacard. It's an ACE, they're all ACE blockers. They prevent the formation of angiotensin II and aldosterone, and maybe some inotropic properties. Patients with congestive heart failure and left-sided heart failure have marked improvement on these drugs. No need to put a patient on a sodium-restricted diet, which is excellent, because they're not retaining the amount of sodium in the body. Side effects, caution with animals that are hyponatremic, because we actually don't want to lose too much sodium, and watch out for hypokalemia, especially when we're using potassium-sparing diuretics. So diuretics, good segue. The goal of diuretics is to get the water out, so to squeeze the sponge. They're given to animals who may be showing signs of fluid buildup, lots of reasons, quite often congestive heart failure, they go hand in hand. We always have to be careful with the dosing. They can be used for emergency scenarios, and we have to ensure that our patients have access to water 24/7, because they'll be losing a lot of water. They'll also want to be replenishing water to a point. Lots of bathroom breaks as well increases their polyuria, and the goal is to enhance secretion of sodium and potassium via the kidneys. The goal, just looking at the sodium and potassium, important to note, sodium and potassium will both retain water in the body. So the goal here is to enhance the secretion, so the release of sodium and potassium through the kidneys to help take that water with it. So we have different types of diuretics. We've got loop diuretics. The prime example, of course, is furosemide. That's one that we often use as an oral tablet, but also injectable in clinic. Thiazide diuretics, we have chlorothiazide and hydrochlorothiazide. We have potassium-sparing diuretics. Spironolactone is a common potassium-sparing diuretic. We have some osmotic diuretics and carbonic anhydrase diuretics, or inhibitors. So we'll talk about all of those. Loop diuretics, these ones are a big one. So furosemide, Lasix, is the most commonly used diuretic used in veterinary medicine. Loop is referring to the kidney's loop of Henle, and it inhibits the reabsorption of sodium from the urine. Loop diuretics do not result in sodium loss from the body, oddly enough, and long-term use they can cause ototoxicity. So, bit of an explanation. Wherever sodium is, water is. If sodium accumulates in the urine production, water will accumulate in the urine production. Because sodium is so important to the body, the distal convoluted tubule downstream from the loop of Henle has an active transport mechanism by which sodium is reabsorbed and potassium is excreted in exchange for sodium. So anytime in this whole secretion absorption system of the kidneys, if one ion is excreted, another one is absorbed. So keep that in mind. If we kick out sodium, we take in potassium. Because of the number of ions in the urine, because the number of ions in the urine has to be the same at all times, and it exerts the same degree of osmotic pressure to draw in or retain water, the diuretic effect continues in spite of the removal of sodium in the sodium forming urine. Sodium in the forming urine. Prolonged use of loop diuretics, which would result in continual potassium loss, may result in hypokalemia. If the animal's diet is not supplemented with additional potassium, then the hypokalemia can occur. As previously mentioned, hypokalemia can significantly increase the risk of arrhythmia associated with digoxin toxicity. So that's one thing we have to be cautious with any type of diuretic that affects the potassium and its use with digoxin. Furosemide and other loop diuretics have been implicated in ototoxicity, which is toxicity associated with hearing or the inner ear. Essentially, ion imbalances, especially with the use of large doses of furosemide in cats, are believed to change the electrolyte balance in the inner ear, resulting in a loss of hearing. So we tend not to use furosemide for long-term in cats, especially in high doses. So loop diuretics, common drug name that we use, furosemide, trade name, Lasix. Mode of action, it inhibits reabsorption of sodium from the urine. Positive effects, it works in the loop of Henle. 90% of the sodium is reabsorbed here, therefore it's fairly effective. So if it's blocking that reabsorption. It's the first line of defense for edema associated with cardiac issues such as congestive heart failure. It can cause hypokalemia, and caution with hypokalemia if the animal is also on digoxin. Likewise with cats, in high dosage or in long-term use, it can cause ototoxicity. Just going back to this one, so long story short with the hypokalemia. So if the body senses more sodium in the loop because it's inhibiting the reabsorption of sodium from the urine, so the body identifies that there's more sodium in the loop of Henle. It tells the body to absorb more sodium in exchange for potassium. Okay? So it's telling the body to do that. It doesn't actually end up reabsorbing because it's blocking that. But that mechanism of action is still occurring. So it's telling the body to reabsorb more sodium because it has an influx of sodium. And when we take in sodium from the urine, we have to excrete potassium. So again, because we end up with a bit of an imbalance between sodium and potassium, the body can continuously be excreting out potassium, causing hypokalemia. Just to keep that in mind, just as a Cole's notes of how that works. All right, thiazide or thiazide diuretics, we have chlorothiazide and hydrochlorothiazide. They're often used by themselves in veterinary medicine for cardiac problems. They act to decrease the reabsorption of sodium and chloride in the initial or early segment of the distal convoluted tubule. They're not often used. Sometimes we use them in congestive heart failure, otherwise they're not used in vet medicine much at all. The interesting with this, it doesn't disrupt the ion balance for congestive heart failure patients, which can be really beneficial if we're looking to provide treatment, offer a diuretic, but not cause imbalance of potassium and sodium. They just aren't as effective as loop diuretics, so most of the sodium is already absorbed by the time through the loop of Henle by the time it reaches the distal convoluted tubule, so they're not really effective in that way. Furosemide is overall quite safe, and it lessens the chances of hypokalemia. Then we have potassium-sparing diuretics. Spironolactone is a competitive antagonist of aldosterone, the hormone that normally causes sodium reabsorption from the distal renal tubules and collection ducts. It increases sodium ion excretion and retains potassium in the body instead. So potassium sparing, it retains potassium. Then we have osmotic diuretics as well. Mannitol is a carbohydrate, so it's a sugar, and it retains water in the renal tubules by its physical presence within the lumen. So in order for, if we think about that concentration gradient, if we offer this large carbohydrate that sits within the renal tubules, then that is going to draw water to the renal tubules in order to rebalance the presence of that large carbohydrate. It's most often used for head trauma though, rather than cardiac episodes. So when we need to decrease the swelling on the brain, we'll offer mannitol to help draw that fluid out. Then we have some other random cardiovascular drugs, or drugs that affect the cardiovascular system or affect the clotting factors of the system. So we have aspirin, which is acetylsalicylic acid, ASA. This inhibits platelet formation of prostaglandins and thromboxanes. Therefore, it reduces the chances for spontaneous platelet plug formation. It must be used cautiously in cats because they don't really metabolize this drug very well at all, and it can become quite nephrotoxic, so kidney toxic. Some sedatives and tranquilizers may be used to calm the anxious animal, thereby allowing their heart to slow. They reduce the heart's muscles' oxygen consumption and improve the heart's muscles' effectiveness. The beneficial effects of tranquilization, they really have to be weighed against any possible adverse effects of sedative drugs, because we know a lot of our sedative drugs and tranquilizers will affect the cardiovascular system, and they're often a cardiovascular depressant. So we have to watch that, especially as it's related to lower blood pressure or decreased heart function.
About a lot of things, and I've been waiting for this day to come. Maybe I